going to get a little deeper into this now on appointments and clinical work. And people often assume that rehabilitation begins with some sort of an assessment or an exercise, or maybe some form of treatment that you're starting to perform on the person. But for me, the rehabilitation process begins with that initial conversation. And the conversation doesn't necessarily fix people, but because by the time someone has come to see me, more often than not, they're walking in with a story. They're not just there because they are having a painful shoulder, their back has been bothering them, they're having some sort of bad knee issue. They have a story they're coming with. And that story is likely developed on their own and through seeing other providers. It's rare that I'm the very first person somebody sees when they have a problem. And sometimes that story they've been working on that they come in with, maybe they've been working on that story for weeks or years. And one of the most important things that I can do on the first day is start to understand the story that they are coming to me with. So one thing that's changed over my career is realizing that I'm almost never the first person that somebody sees. And that's been true for a long time. And by the time that they get to me, they've often seen multiple different providers, surgeons, medical physicians, other physical therapists, other chiropractors. Maybe they've had some imaging done. Maybe they've tried an injection or two. Maybe they've already had a surgery. Maybe they've already gone through some sort of long physical therapy or chiropractic treatment plan. They've had massages. In this day and age, they've likely spent a fair amount of time on ChatGPT, Google, and social media trying to understand what is happening to them. And every one of these experiences is going to leave an imprint on them and help develop the story that they have when they come to see me. Sometimes those things are useful. Sometimes, but I would even argue, most of the time, those things are limiting. And usually there's just a little bit of both happening. They've gathered some useful information, a little bit of limited information, or a lot of limited information, and now I've got to help them unravel the story that they come to me with. So they don't just bring their pain to the office, they're bringing their conclusions about the issue. Somebody told me I would never squat again. Somebody told me that I should never do any deadlifting. Somebody told me that my low back is unstable, whatever that means. My shoulder is wearing out. I was told that I could never, kneel on the floor again. And whether these statements are exactly what was said to the person, that's kind of beside the point. It's more how the patient interpreted what was said to them. And, I don't really know. I wasn't in the room with them, but it's important to always remember that as I'm starting to unravel the story. I always have to remember that I wasn't there, so I can't make a lot of presuppositions. And something that I've been doing for a long time that took me a while to start to refine is working on my ability to challenge the stories and narratives that a patient comes to me with without criticizing any of the clinicians that came before me. And it's harder than it sounds. It's a skill I see people, all ages in clinic, neglect to develop. I don't know what was said by the other provider. I don't know what kind of information that provider was working with. And I don't know that the patient even heard them correctly. And, and honestly, it doesn't help anyone if I spend that first appointment tearing down what some other provider told them. It's useless. It's not time well spent. So instead, I become curious. I start to ask questions. What were you told? What did that mean to you? How has that changed and what you're willing to do? Those answers are often more important than the diagnosis itself. And one of the biggest shifts in my thinking over these years is realizing that the patient's story isn't separate from the rehabilitation process. It's a big part of it. And if someone believes that they should never bend over again, that belief changes how they move. And I need to start chipping away at that belief. If someone believes that a knee replacement means that they're never going to be able to kneel down again, that's going to change how they live. And I need to start finding a way to chip away at that narrative. If someone is believing that this disc bulge means that their spine is fragile now and it's one wrong move away from exploding, that's going to impact every single decision that person makes throughout the day. And when those beliefs become clinical findings to me, just as much as like a weakness, stiffness, or some sort of pain response the patient's having. And I'm going to go back to something that was kind of, I didn't notice at the time, but it's become kind of a powerful narrative in my thinking. And I was overseas, I was in Abu Dhabi doing some work, and they brought to me a guy who had bilateral knee replacements, and he was told by the surgeons that he's not going to be able to kneel anymore. And for some people, this isn't going to seem like a big deal, but for him, this was directly affecting his ability to do his daily calls to prayer, in the way that he wanted to practice his religion. And at that point, you realize this isn't just about the ranges of motion of his knee. Everything about having his knee replaced is touching on his personal identity, his ability to practice his faith, and these are really important things in his daily life. So, I had to sit back and think hard about, not forcing anything, not ignoring completely what he was told after surgery, or at least what he thought he was told. And we're not going to pretend that there's no limitations. We're just going to start to simply work on slowly changing the story. And gradually over time, you get somebody like this more comfortable getting down, then more comfortably kneeling, and more comfortably bending the knees in that kneeling position. And it's not just that his knees adapted, it's that his understanding of what he thought was possible for him after the surgery started to adapt. And that's a more powerful thing. And a big mistake I do see clinicians make is they think that helping somebody change the story they're telling themselves means telling them that everything that they have been told before today is false. And that's not what I'm doing at all. And that's not what you should be doing. I'm trying to help them keep all the information they've brought to me in perspective. Just like in my MRI video you can go look at, the goal isn't to dismiss any piece of information that they're giving me. The goal is to decide how much weight each piece of information deserves as we move forward. And sometimes the story that they've been carrying simply has been given too much power over them. And that phrase that I like to use, let's not give this too much power right now, becomes very useful in these situations. And what I'm not saying is that this piece of information doesn't matter. What I'm saying is that we need to decide together how much it should matter as we start to make a plan to get better. And this is why rehabilitation starts before any exercises are prescribed. If I can help somebody better understand the story that they've been living with, then we can help them recalibrate that story without being dismissive. And we can create just enough room for different possibilities. Then we've already started the rehabilitation process. And movement isn't just physical, it's psychological. And people's willingness to move can help change before we even apply any sort of movement to them. So during the first appointment, if I had to summarize what I'm thinking, it's going to be something like this. I'm starting with a history. Why are we here? And then I want to sit back and try to understand the inherited story and narrative that they are coming to me with. So I just let them talk. What stories they're carrying, what beliefs they have about those stories that are shaping all their decisions. And what does all of this mean to the person? That's always a question I like to ask as they wrap up the story that they've brought me. And then we start to begin some clinical reasoning. Then we're going to start to move. And we're not starting to move to prove a point. We're going to start to move around to gather some evidence. And I'm going to try to create a new experience for the person and start to replace their fears that they came to me with some capabilities. And then we're going to try to decide what is the highest leverage intervention that we can implement now for this person. And for the longest time when I first started, I thought my job was to help people move better. Okay, and that's important, but the longer I practice, it's something else that's important. They don't just need strong muscles, they need a stronger story to live in. And not a story that is going to completely ignore the reality of the situation, but a story that is starting to leave room for them to explore and adapt, and is going to leave room to make progress, and is going to leave some room for possibilities in the future. And a lot of times that means that the first intervention isn't even an exercise. It is just helping someone realize that their future that they've imagined isn't the only one that's available to them.